You do a lot of speaking at conferences like this, the A4M in here in Florida. Can you just discuss a little bit about your background in things like autoimmune disease? You touched on that a little bit earlier, and that's something I think that concerns so many people these days.
Yeah, autoimmune disease is really, it's become a great passion of mine into really understanding it, following the literature and publishing in the literature about it. And it was really a passion born out of desperation because I'm in clinical practice. And I have to tell you, in the 20 some years that I've been practicing, it's an epidemic. I mean, it is so much more prevalent than it was 20 years ago, even in my span of my career. And it's not just because we're better at diagnosing it. It's not just because I'm, more aware of it. It truly is an epidemic, and there are a lot of things driving it in our lifestyle, in our culture, and for some reason, the body's immune system in a lot of us is deciding to attack us instead of what it's designed to do, which is attack threats, foreign invaders, bacteria, viruses, parasites, things like that. Something is tipping the scales of the immune system to start kind of spinning off kilter and not recognizing us as us and not attack us, and recognizing what it needs to attack us. So when I really started delving into this and looking into the scientific literature myself, I found a lot of different hypotheses out there, some of which are extremely compelling, have great evidence base for them, but have never found their way yet into the practice of clinical medicine. So the practitioners aren't really using, the conventional practitioners, I'm talking about if you go to a standard rheumatologist or a rheumatology center, or you talk to an immunologist, they're not really going to these places, but the researchers are. And the researchers are absolutely convinced. But we know that the research is usually running about 20 years or so ahead of the practice of clinical medicine. And I think that divide is getting worse, not better. And you would think it would get better because information flows so much quicker with the internet and online databases and PubMed and all of that. But in reality, there are sort of commercial forces and political forces and standard of care committees and things like that that really almost dampen down the time that it takes to get new ideas into use. And we want to be careful. We don't want to just jump on the latest thing that might end up being harmful, but the kind of things I'm talking about are not things that have a downside. They're things you can put into play with people that really they don't cost a lot, therefore they don't generate a lot of revenue. That might be part of it, but they really don't have a risk profile to them. So why not, right? Why not try it? And some things, like, we know that there's strong association, and now even data showing causality between the ingestion of certain dietary food proteins or peptides and the genesis of autoimmune disorders in genetically susceptible people. So it's not in everybody, it's in people that have a genetic pattern to build certain type of what we call HLA antigens, human leukocyte antigens, that present different proteins or different peptides to the immune system and sort of hold it out saying, hey, this is not me, this is something we need to react against. So the most classic example would be, let's say, celiac, where if you have the genetic propensity towards celiac disease and you eat gluten, gliadin containing grains, such as the field grass grains, wheat, barley, rye, things like that, you will take in that gluten or gliadin when you digest those grains down. It will come through the GI mucosa. Your immune system will grab it, and certain T cells with these HLA antigens on it will take that and hold it out to the rest of your immune system, basically screaming, saying, this is bad stuff, react against it. Try to do something to neutralize it. Other immune cells come in and you get this immune proliferation, which creates sort of a runaway train of immune response. And your body at some point stops being able to discriminate between the structure of these food-based proteins or peptides, such as gluten or gliadin, and some host proteins that are on your own tissue. For instance, we know people that have celiac disease have 20 times the rate of autoimmune thyroid disorders things like Hashimoto's disease and Graves' disease. And it's because there's a structural similarity between some of the receptors on the thyroid, which are proteins, and this gluten and gliadin fragment. The body stops being able to tell the difference, the subtle difference in structure, and now the immune system drives itself against the thyroid as well, attacking that, inflaming it, and you end up with an autoimmune thyroid condition. So that's a process known as molecular mimicry. One protein looks enough like another where if your immune system is not exactly right and can't discriminate anymore, it'll cause a cross-reaction to your own tissue. So we know from the medical literature there are different triggers for this molecular mimicry phenomena. One is food proteins. So while celiac disease is the most overt, there are many, including with gluten and gliadin and those field grass grains. Short of celiac disease, you can have lower levels of response against it, which people are now calling gluten sensitivity or gluten intolerance. But it's not only gluten. There are people, for instance, that have significant responses against some of the proteins in cow's milk or in dairy. And in fact, one of the main triggers of type 1 diabetes, formerly called juvenile diabetes, is when you give a genetically susceptible child milk, cow's milk, their whole time growing up, they react to one of the bovine albumin peptides, which has a structure similar to the proteins that are on the islet cells of the pancreas that produce insulin. So over those years, the body's kind of generating this response against this cow's milk protein, and there comes a time when you cross that threshold, and now it very rapidly sees these pancreatic cells as the enemy as well, takes them out, and now all of a sudden this formerly perfectly healthy young person passes out, gets taken to the emergency room, and has a sky-high blood glucose level, and they get diagnosed with diabetes, and they're on the insulin train. Well, if we could have found those people who are genetically susceptible very young on in infancy, and you can test it now, and keep them away from dairy. Now, the dairy industry doesn't want you to know this, right? Or the food pyramid or whatever. But those, not everybody, but those folks, if they were kept away from dairy, you can theoretically at least stop them from ever getting diabetes. But those are sort of more dramatic examples. There's a lot of shades of gray in there where people have all these vague, chronic conditions that are driven by inflammation, because when your immune system attacks yourself, you become inflamed. Well, all the chronic diseases of our time are inflammatory disorders, whether it's heart disease, whether it's diabetes, whether it's arthritis. The other thing that I've really lectured on a lot is changes in pattern of the microbes, mainly the bacteria, but also viruses, parasites, and others that grow in our intestinal tract, and that's known as the microbiota. The microbiota are all the critters that live in our gut, which is a hollow tube running through the middle of us, which is technically outside of us. It's not our own body, it's this tube running through the middle of us, and it's this whole foreign environment full of all these bacteria. And in fact, the bacteria outnumber the cells of our body by at least a factor of 10. So we think we carry around all these bacteria, and in reality, by numbers, the bacteria are carrying around us. But they interact with our immune system at the level of the GI lining or mucosa. And if we get the wrong components there, if we get an overgrowth of opportunistic or even pathogenic bacteria, it can send our immune system off kilter. And actually, these microbes, these bacteria, have proteins on them and have other elements that they excrete or they're metabolites, or it's part of their structure when they break open, that our immune system reacts to, that can also cause this molecular mimicry phenomena. Let's go back to thyroid autoimmune disease like Hashimoto's. That can be triggered by eating gluten if you're intolerant to it, but it can also, we know in the literature, be triggered if you have an overgrowth of a bacteria in the intestines known as Yersinia. Yersinia on its surface has proteins that look just like the TSH receptors on your thyroid. So your thyroid responds to thyroid stimulating hormone, which your body makes. And if you get an overgrowth of this Yersinia over time, you can have an immune response trying to beat down that infection, which eventually turns on your thyroid. There's bugs known as Klebsiella and Citrobacter species that can overgrow in other people that have a cross-reactivity eventually with the synovial linings of the joints, which can drive rheumatoid arthritis. But there are bugs that commonly cause gum disease or periodontal disease, like P. gingivitis, which is also known to drive a process which can end up as rheumatoid arthritis. There's a bug called Proteus, which can overgrow in people's urinary tract, in their kidneys, in the urethra, in their bladder, particularly in women who are more susceptible to urinary tract infections. That can also result in rheumatoid arthritis. And there's a great researcher from the UK, Alan Embriger, who's spent his career researching this link between Proteus and rheumatoid arthritis, Proteus in the urinary tract. And it really explains a lot of the things we learned in medical school about rheumatoid arthritis, such as why it only affects the small joints and spares the large ones. They told us that in medical school as a factoid to look for it in diagnosis, but they never told us why, because they didn't know why. Well, we do know why. It's because the small joints have a type of collagen known as type 11 collagen. The large ones don't. And the molecular mimicry between one of the things produced by the Proteus organism and the joints is to type 11 collagen. That's what the structure is similar to. So now we know why it affects only the small joints. But all of these things have not found its way into general practice. But when they come see an integrative or functional medicine doctor like myself, who understands these connections, we can test them for how their immune system reacts with different dietary proteins. So we can test 150, 200 foods and look at how their immune cells react to those foods, get them off of the foods that they're not immunotolerant to. We can do stool analysis or mapping of the microbiome or the microbiota of the gut more specifically, and looking to see, do they harbor these organisms at higher levels than normal, which we know can translate eventually into an autoimmune process. And if we can get rid of those bugs and put more of the good guys in there, get rid of the bad guys, there's no downside to doing that. It's not expensive to do that, but we're getting them off of that train that's rolling down the track toward autoimmune disease. And finally, we test what are known as autoantibodies. We can test in blood for autoantibodies against your own tissue that you're developing 5, 10, even in many cases 15 years before you ever would have enough symptoms for a doctor to diagnose you with rheumatoid arthritis or ankylosing spondylitis or multiple sclerosis or lupus or you name the autoimmune disease. There are autoantibodies that we can find many, many years beforehand. And then if we find them, we know that you're genetically susceptible to getting that unless you change something. You need to change the landscape. You need to change the environment. What is the environment you change? You change 3 things. You start eating foods only that you're immunocompatible with, and you definitely avoid foods that in the scientific literature we know is a trigger for that autoimmune disease that you have autoantibodies to. We do stool analysis, we map your microbiota, we get rid of the bad guys, particularly ones that we know are associated with the autoimmune disease that you have autoantibodies to, and we just improve the landscape. More good guys, less bad guys living in your gut. Finally, what we do is we make sure that your lining of your intestine is very healthy. So we'll give you the types of foods, we'll give you the type of nutrients in supplement form that feed the gut lining so you don't have something known as hyperpermeability, commonly called leaky gut syndrome, okay, which is now the big topic. There's a lot of very prominent researchers in the ivory towers of academic medicine now proving that leaky gut syndrome is a big component that has to be there as one of the major components to have autoimmune disease set up. And they're working on drug agents that will deal with leaky gut syndrome. Meanwhile, in functional medicine, we've been dealing with leaky gut syndrome, and that hypothesis at least, and treating it for as long as I've been doing it, which is almost 25 years. But now it's real, I guess, because they're developing agents, that will be pharmaceutical agents to deal with it. So those are in trials now. And my prediction is that while leaky gut syndrome was always poo-pooed by the orthodoxy as, oh, that's just this thing that all these strange integrative docs or functional docs or naturopathic doctors talk about, which isn't really real. Once these drug agents hit the market, you will see on television commercial after commercial for leaky gut syndrome. I guarantee it's going to happen once it's commercialized. So it's funny, we've seen that with other things. For instance, low testosterone in males, right? That was always, oh, that's heresy, that's ridiculous, that's not an issue. Now you can't go 30 minutes on television without seeing a commercial for low T syndrome. It'll be the same kind of thing.